Well, hello. In this class, we are going to complete what we started a couple of weeks ago, speaking about voice and the part of the diagnostic assessment that we will do in terms of the procedures. But keep in mind that this class, when you study diagnostics, you mainly focus on the overall aspects of the process itself of how to go about diagnosing and conducting the diagnosis rather than doing a differential diagnosis. As you could see, we have many kinds of voice disorders, and when you look at the voice class, which you will take over the summer, you are going to find that it will give you time to do differential diagnosis between, say, isolate one disorder from a group of voice disorders. So the purpose here is when we know, for example, someone is referred to us with concerns about voice, how do we go about the diagnostic process itself, and the procedures, and so on. But in the process here, I would like to go back and give you some examples and flesh out some of these kind of terms and put them in practical context. And then we'll jump directly after that. We will go to the part where we speak about the perceptual assessment of voice, and then the instrumental assessment, and then the auditory acoustic analysis of the data that we have. And so here we spoke about the three major categories of voice disorders. We spoke about functional, which means that it is a problem that results from how the vocal folds are used. Okay, and we understand that in some cases when someone uses his or her voice abnormally, like say mimicking animals or making growling noises or speaking excessively for extended periods of time and so on, that is functional. That is going to cause physical damage to the vocal folds, and that is going to make the problem organic. However, there are problems that begin as organic and then they will cause the voice to be bad. For example, rhinitis edema. When we spoke about people smoking and then developing the tissue abnormalities, that is going to change their voice. So in that case, that is an organic problem, or a cyst or a papilloma. These are all organic in nature from the beginning. But as I explained before, there are functional problems, problems using voice appropriately, or in a manner that is, for example, adequate in terms of timing and pitch and all other aspects. And if that use is not appropriate, that will lead to physical problems or organic problems. And then we have the neurological. That is about the smallest and easiest category. The person would have, let's say, unilateral vocal fold paralysis or bilateral. I explained that the unilateral is most common because typically strokes happen on one side, and that will impair just one vocal fold. Remember that the vocal folds are innervated by the recurrent laryngeal nerve and also other and parts of the larynx are also innervated by that, and there are branches. Basically, these are branches coming out of the vagus nerve, which goes into gives off branches to the neck area and the larynx, and then it goes down to innervate the rest of the trunk, the organs, internal organs. And then we have bilateral paralysis, and then we have spasmodic dysphonia, and then we have essential voice tremor. At the end of the slides, you are going to find links for different cases of voice disorders. The best way is for you to listen to these actual patients and have a sense of what the sound is like when someone has a spasmodic dysphonia. There are different kinds of this dysphonia that you are going to study in the voice class. And then the essential voice tremor as well. So now we spoke about the functional category being the biggest category. In that category, there are psychological things, for example, psychological kinds of problems that are associated with stress, with tension, anxiety, and various psychological, causes. So this category is a big category that both includes the inappropriate use of voice and the excessive use of voice, for example, raising loudness and screaming a lot or speaking too much, for example, on a regular basis. These are parts of the functional. And also then you have ones that result from psychological causes, so that will lead to stress and muscle tension that is going to have an impact on voice. I'll just give you one example of these. Puberphonia, for example. There are cases where it is not very common, but cases where a child who is 12 years old, or once the child, a boy, for example, as he transitions into the adolescent period and the vocal folds become big and massive, and then they should be vibrating at a much lower pitch, just like an adult. Yet the person, despite the physical maturation being, quite impressive, and the, characteristics of being transitioning into adulthood basically are there, but the person is still speaking in a high pitch that he was using as a boy. And when you look at that, that is basically an abnormal way of using the vocal folds, because in that case, the boy would be putting so much tension and causing the vocal folds to be elongated and tense, so that he would keep that high-pitched voice, which is not natural for his, the mechanism. So that constant, like as I mentioned, raising pitch requires putting a lot of tension on the vocal folds. And now if this is happening every time the boy speaks, that is going to cause a lot of more tension and pain in the neck area. So that is one. And of course, the SLP would need maybe one session, maybe 2 sessions. And most of these cases are resolved in just that 1 or 2 sessions. And in rare cases, you would need to send the person to a psychiatrist or to a psychologist to discuss, possibly underlying psychological issues. However, in the majority of cases, the trained SLP should be able to resolve these issues in 1 to 2 sessions. So that is one example I'm giving you of the functional, which is psychologically based. The other one is, let's say someone has, for example, a singer, and singing and performing, like continuously throughout the day for several times a week, and putting so much of a strain, that would be called hyperfunctional vocal use. And that is going to cause these typical symptoms of vocal nodules, which is going to create that kind of hourglass configuration of the vocal folds, where they meet at some point when there's like a protrusion or ulcer, some kind of, not ulcer, but some two swellings. And then when the vocal folds come together to meet, then these two little points are going to meet in the middle and prevent the rest of the vocal folds to meet on either side. So that is going to cause the breathiness that is characteristic of vocal nodules. So that is, again, the other one. And typically, teachers tend to develop it because they, that is, you make a living by profession. And that teachers also include professors. So when, as they rely on their voice throughout the day and constantly, if they go beyond what the mechanism allows, that is going to make them develop a vocal nodules. And of course, other voice problems. However, this is a common one. So let's look now at some different, kind of organic things. I would say images of the vocal folds, and then we'll look at different examples. And just to give you an idea, again, the class here, the assessment class, is focused more on the procedures of how to go about the assessment. But I would like you to have a context so that as we speak about the details of perceptual and instrumental assessment, then you should have that in mind. So let's look at some of these cases. So here are the vocal folds. You notice the edges here. These are normal vocal folds. If you are feeling that one is bigger than the other, that is not the case. Just look here, the distance between this and this area here. And look at the distance between this and the other area. What this is telling you here is that the camera was tilted more towards the side. So it is showing more of this vocal fold than this one. But the mechanism and, generally, if you look at the vocal folds here, they are nicely smooth all along the edges here. You shouldn't see protrusions. So that is how, the vocal folds are normally. And you could see how that whitish kind of lining on top, that is the mucosa, that consists of the mucous membrane or the epithelial membrane. And right under it is the SLP hiding. No, the superficial lamina propria. So these two pieces are the ones that are most responsible for the vibration. So here, what happens, look at this one. Here you have laryngitis. That's the case of laryngitis. Now you have both sides of the vocal folds. They are inflated, filled with fluid, of course, because an inflammation this is what it does. Look at the blood vessels. They are all filled with fluid, and the whole area has a lot of redness here. But so now this person, when he or she speaks, what do you expect? Will they have a higher pitch or a lower pitch, and why? Now this is speech and hearing 101. The things that determine vibration rate, that determine the frequency, include mass, length, and tension. So look at mass, the mass here. When you have a vocal fold and then put a lot of, basically fluid into it because of the infection, that vocal fold will vibrate at a lower rate. And that means the person will have a lower pitch. And this is why when you have laryngitis, you have that. But where does that gravelly voice come from when you have laryngitis? Laryngitis is basically are inflating the vocal fold, not just from one side. The top is inflated and the bottom of it is inflated. Now that makes the edges, the normal edges that are supposed to vibrate, they are not lining here on the area when you put them together. And you notice all these abnormal kind of, protrusions, and there's lack of a smooth line here that you saw here. That is not there. And when you close these two vocal folds, you're going to have little gaps here, and here, and here, and then here. So all along, you're going to have these small gaps, jagged, and then the air escapes through them as you are speaking, and that causes that gravelly kind of unpleasant low-pitched voice. So that is what we mean by hoarseness and for example, harshness. When you have lots and lots of these uneven spots and the edges are not even, then low pitch, then you are going to have lots of basically a combination of breathiness and a combination of hoarseness that gives you that harsh kind of voice. So in the case now of, as we see here, yes, this is laryngitis, but the person also has some kind of, problems here. But let's look at this one. You can see this edge is smooth, this edge is smooth, and here and here. And when you put this, you close the vocal folds through arytenoidal adduction, you'd expect that this spot will meet this spot, and then they will touch each other first before this area and that area. So that means you're going to have that hourglass configuration where you have an area that's not closing here and an area that's not closing here. And that gives you the breathiness. That means that kind of air going out and escaping and adding noise to the sound the vocal folds are making. And that is basically, again, because the air is escaping through, but the edges here are smooth. So again, if you add, see like that, that's the hourglass configuration. So if you have, for any reason, other spots here that are not even, you are going to have hoarseness and or that combination that we know as that causes harshness. Now, when you look here, that is just snot. That is just mucus here, like here. So that these are the signs. These are the vocal nodules. Just to be aware how they develop. If you take a vocal folds and divide them into three segments. So three, like here's from this point to the end, that's the anterior 1/3. Okay? Anterior 1/3. From here to here, that is the middle 1/3. From here to the end, that is the posterior 1/3 of the vocal fold. Vocal nodules, just because of how the mechanisms of opening and closing, like opening and closing a pair of scissors, at that particular spot, it receives the maximum impact. So as we hit them, keep hitting them back and forth against each other, this area somehow receives the maximum impact. So under these conditions, when there's vocal hyperfunctional use of voice or extended vocal use, there would be like too little kind of areas of inflammation here. Usually it is one, and then it continues to hit and hit until it creates another one on the other side. And then you put them together. And so typically vocal nodules emerge or develop on the posterior end. Okay. This is the anterior 1/3. On the posterior end of the anterior 1/3, or between the posterior end of the anterior 1/3 and the middle 1/3, the middle third of the vocal folds, just in this spot. So again, that is characteristic of vocal folds, and this very easy to identify when you do laryngoscopic examinations. So here we have a polyp. And the polyp is basically a little extension kind of that grows, and it's filled, a sac filled with fluid, and it also mostly on one side, and it comes in different shapes and forms and kinds. So when you close now, they are not closing. And in addition to that, you need to know that the two vocal folds must vibrate exactly at the same speed. If you have one of them heavier than the other, what kind of voice will you get? I hope you said diplophonia. So if this is a massive kind of, polyp or cyst that makes one vocal fold heavier than the other, then you are going to have diplophonia, which is like two different voices coming out of a pair of vocal folds. Here is a kind of cyst that is embedded in the tissue and making the entire vocal fold bulge. Definitely, if that person, you hear that person speaking, you are going to find diplophonia. But you could notice how the blood vessels are enlarged, and this whole thing is embedded in the space between, basically in the superficial lamina propria and the base of it. So that is going to, most of the cases require surgical intervention in that regard. There are some cysts, if they occur within the first few weeks due to particular things that cause them, like behavioral or environmental, you could probably, it might take a little bit to heal, but some of them do heal. And some you must have surgeries for. Here's another kind of cyst that develops, and then on top of it, there will be kind of tissue growing, and that is, it's called epidermal. But don't worry about it. So a cyst is basically a sac filled with fluid on one of the vocal folds. Sometimes it is sitting embedded in the tissue. Sometimes it juts out, and it's like almost like a mushroom. It has like a neck. There is a polyp here, so closing the vocal folds now, they are, in the very, this spot, they cannot close well here. And you could see what this kind of gap is and what that is. That's a massive kind of, okay, let's look now. You will, I'm sure recognize what this is, of course, smoker's edema or Reinke's edema. So you could see now, the person basically has little space to breathe, and the voice will be really, really low pitch and unpleasant and diplophonic. This is some kind of cancer, laryngeal cancer, and you can see subglottic, supraglottic. It is in the everything basically above the vocal folds, and the growths and different, abnormalities, definitely that, what the consequences of this will be. This is laryngeal papillomas. These are virally caused, and the papillomavirus, children, babies are exposed to it if the parents have it. The babies, as they are born through the birth canal, they are exposed to this, and they could have so many surgeries in the early years of life, and these will be removed, and they come back, and removed, and they keep coming back. So this is a granuloma. Some granulomas occur, for example, sometimes they're called contact ulcers. Some of them occur because of hyperfunctional vocal usage, when you yell and scream and really, really use your voice in a very abusive way. Then the areas, vocal processes of the arytenoids will be slammed and slammed and slammed against each other, and then you have one granuloma. In some cases, they might develop because of intubation. When someone has a surgery or they have a tube for a long time, that can cause irritation, and that can cause that to develop there. So you notice when you close now, there's a huge gap, and the vocal folds will not vibrate. The person will be basically whispering. So that's a granuloma, and the typical site of that is on the vocal process of one arytenoid. This person had intubation, and then because of the irritation here that was caused by the intubation from both sides, the tissue then, in order to heal itself, made a bridge and just basically connected the two vocal folds in the back and immobilized that area. So that is, in some cases, these are caused by surgeries. Okay, so now we are going to go with that background. We are going to speak about the process of doing a auditory perceptual assessment of the voice, basically using your senses, your judgment to determine, to describe the nature of the voice, to determine the case history, to do, get observation about how the person behaves and so on, and to get language samples and everything else. So then you want to confirm your results. So you are gonna, if you suspect a disorder, then you are gonna send the person for, or if you are the SLP in the hospital, you will do the instrumental evaluation. And then you will, part of that instrumental eval is auditory acoustic analysis. So I'll skip to this area, and this is the before you do the perceptual assessment, and we discussed that already. So we'll just jump in, just come to the assessment. Again, perceptual, we call it perceptual because perceptions are based on our senses, and every one of us has different senses. And as a result, everyone will perceive things in a different way. Someone might see something and someone might not see it well. Someone might hear better than another, and so on. So that is some kind of a judgment call. That is, it is our subjective kind of description and assessment of the voice and the voice quality and the pitch and so on. So it relies on information that you collect from the case history because you want to interpret. For example, you might say, well, I notice a lot of tension here around the person's neck. Or I suspect that this person has probably some psychological causes that are causing the abnormal pitch or abnormal use of voice. Then you go into the case history and look for signs of stress, signs of anxiety, and you kind of look at the attitude and explore all the information you collected so it can help you interpret what you have observed. And then the clinical observation is something, as I explained, that you do throughout the evaluation from the minute that you see the client until the very end. And you write notes, and you are going to need this because as you go through the assessment, you're going to say, oh, I think I saw him do this, or I heard him say that. And then you can go back to your notes and get examples to support your conclusions. Then, of course, you get the information also from the patient and family and so on. You do part of this also, you look at the CAPE V, kind of voice to get information about the person's emotions and how they use their voice and so on. And also the voice handicap index. It assesses, as we discussed it before, the three major areas, basically looking at causality and the effect on the person's life, and also behaviors that the person might be engaged in. to make the voice worse. And in addition, so you have the voice handicap index, and then we use some simple tasks that enable us to determine the use of the voice, and also use diagnostic probes. Basically, these are like stimulability tools. You use them to see what improves voice, what improves the patient's voice. For example, one of these could be if you observe that the patient is sitting and slouching and not breathing adequately, then one of these probes, stimulability, that you use to improve the voice to see if it works. Say, I'd like you to sit up and straighten your shoulders, and I'd like you to take good breaths, and then have enough air, and then speak. So you will notice that, for example, that is making the voice clearer, louder, and is making the pitch better, and so on. That could be then used as a strategy that you will write in your report at the end, part of your recommendations, that the person should do this and that. So there is a wonderful resource, the Asha website, and it walks you through all the steps of the evaluation process. And let's see, I'm just gonna walk you over and summarize some of the points. Let's see, hopefully it will start. It's taking much longer. All right, I would like you to visit the website, just so that we can avoid making the video too long. But it goes through the entire process from the case history until the very end. It gives you lots and lots of resources, like the portals that I showed you in class when we spoke about AAC and swallowing. So perceptual assessment, again, you are going to get lots of samples through little tasks that you do. For example, some of the activities will be asking the patient to count. Maybe, for example, count from 1 to 20. And, for example, you use that for pitch. If you say pitch, you go from the lowest pitch to the highest pitch, and you see how gradually, how long it takes the person to go up. And the longer it takes from the lowest pitch to the highest pitch, the better it will be. And we call that is the pitch kind of range. You do that also for intensity. So you could also do singing and humming, for example. Sound extensions like E, and you do it as beginning with high pitch, low pitch first. And you keep going higher and higher and higher. You start with the lower because that's where the person is relaxed, and then you keep gradually going as you go to the higher and higher pitch. That's going to add more and more and more tension, and you keep, going and see. Ideally, you need to have a wide range, and the wider the range is, the better. For example, singers are trained to have a very wide range where they can raise their pitch in small increments, from the lowest to the highest, and it takes them a long time, and they go way high in pitch, higher than the average speaker. And the same, you do the same with loudness. People who have voice disorders will have a restricted pitch. They cannot lower their pitch. For example, the pitch is low. They can't raise it to a certain level, and if they start raising it, it will start to hurt. Looking at quality, for example, is you speak about how do you describe your voice? Raspy, describe it as hoarse, as gurgly. So these quality, descriptors of quality are more kind of subjective, but we have some common descriptors that we use: hoarse, harsh, gravelly, and so on. Stimulability, when we speak about voice assessment, usually it means probing. So the probe that you use is something that you use to see if it will improve voice or not. And if it does, then that will be a strategy that you will recommend in your evaluation report. So the first part of the auditory perceptual assessment is to look at the oral peripheral mechanism. Look at breathing. Is the person breathing adequately? Are the two parts of the breathing cycle kind of in synchrony with each other? And is breathing in synchrony with voicing? And is voicing in synchrony with speaking? For example, does the person begin speaking when he or she has enough air? Now they have started, the person takes a breath. Does the person begin immediately after breathing, or, after inhaling, or release a little bit of air and then start to speak? In some cases, that you could use it either way. In some cases, if the person's voice is loud and there's a problem, then you see they might not wait enough. They might take an inhalation. They have a lot of air and then they start, speaking. The voice will be very loud and it will be, for example, different and so on. And in that case, you might have the person just release a little bit of air before he or she begins speaking. That will improve or could improve the voice. Or in some cases, the person might be not speaking as soon as they have the air in. And that means for, especially people who have problems with, muscles and weak muscles, then you might ask them, instead of waiting and releasing a little bit of that inhalation, then immediately as they inhale, let them speak. So when they have enough air supply and so on. So this is just one example, but you notice, you look at breathing, is the person's breathing clavicular like this, so breathing and lifting up, their shoulders? Is the person's breathing thoracic, abdominal? So all of this is in your anatomy class, and you should be able to kind of understand the patterns of breathing and how they relate to speaking. Look at the neck. Are there signs of tension in the neck area? The mandible. Does the person speak with clenched teeth or minimal jaw movement, for example? Or so any of these that you notice that might not be adequate or normal, you need to write them down, because use them as probe and say, well, I noticed that person didn't open her jaw much when she was speaking. One strategy is to make her speak when, opening her jaw more, and that is going to improve pitch and resonance, and it will improve voice in many cases, in some cases. So is the larynx, for example, easy to manipulate digitally, not with a machine, but your digits are your fingers. So in some cases, when there are certain situations where it's so much rigidity and stress, the person's larynx is not possible to manipulate. If you hold it and move it to side or up, down, it is not flexible. So you notice that and you try it and see, of course, wearing your gloves, and you see if you can digitally move the person's larynx left and right. Because a big part of the treatment and the testing is done. It involves laryngeal massaging or laryngeal manipulation. You look to see if there are signs of asymmetry, decreased speed, for example, or restricted range of motion in the oral facial musculature. In addition to the rest of the things that you would routinely assess in the oral peripheral mechanism exam. However, here we are emphasizing more of the voice component. You ask now, look at these problems that you notice, for example, and say, okay, is there evidence of breathiness in the person's voice? That's when you look at the quality. Is there evidence of roughness? And if there is, immediately say, what is causing it? That is uneven edges of the vocal folds. And if someone doesn't have laryngitis, and, for example, they did not have laryngitis over the past 10 days, and they're coming to you and they have roughness and breathiness, especially for a while, then immediately you should refer them to the ear, nose, and throat doctor. Pitch breaks. The person just speaks in a particular pitch, and then immediately they switch to a very, very different pitch. So, phonation breaks. You speak and then your voice is interrupted. You switch from voicing to whispering, just in an, on and off. Do you notice diplophonia, which means one vocal fold is vibrating faster than the other, and in some cases. So, do you notice voice tremor? Look at the video, for the video, and listen to that. Wet or gurgly voice. As I explained, this also is a big sign of swallowing problems, because swallowing and voice are related, as you could see, especially when we speak about laryngo-esophageal reflex. And then once you have explained, do these exist, then you go back and say, to what extent, how severe, mild, moderate to severe, severe, and you explain any of these characteristics that exist, and you word your statement in the report, for example, like this. The patient presents with, or there are signs of. So if you say the patient presents with, or presented with, because the evaluation is like a picture that you take once in time, and then the next day it might not be 100% the same. So the patient presented with signs of breathiness, or with a breathy voice quality, or presented with for example, if you add the severity, mildly rough voice, for example, characterized by, and then you explain. But this is a phrase that you could use, the patient presented with, and you could also say, there were signs of breathiness, for example, or signs of pitch breaks, and so on. In terms of voice, voice quality, you also look at loudness. Is the voice loud enough? And you put that in context of things that would make the person's voice not loud enough. Like, what are these? Could be a stroke causing dysarthria, for example. Could be anxiety that is causing the person's muscles to be, for example, kind of constricting in or contracting in times when they shouldn't be contracting. Like, you want to take a breath, you want to expand the thorax. So you have muscles that should be kind of elevating the thorax, but there are also some muscles, on the other side, muscles of expiration, that could be tensing when they are not supposed to be tensing. And as a result, you have the muscles working against each other, and the person cannot inflate the thorax to get enough air in their lungs. And as a result, their voice is not loud enough. Loudness is a result of how much air you have in your lungs, and how much of that air can help you build up subglottic pressure that you can push between the vocal folds to make you project your voice and make your voice loud enough. So that could be neurological disease causing weakness, and it could be also psychological disease causing the muscles to work inappropriately, and to be tense, so as not to make the person enlarge the thorax enough, expand it enough to have enough air, and to kind of project their voice. You look also for signs of high resonance. I explained to you that resonance doesn't have to do with the vocal folds per se. Resonance disorders have to do with abnormalities in the vocal tract, the path, that amount of air you have in your throat, or the way that your throat is shaped. The vertical pharynx here is vertical, and then the oral cavity, nasal cavity connected to it. So any abnormalities along, if for example, the soft palate is not working well and so on, that will cause resonance problems. One of the most valuable resources that, for example, I have encountered is the textbook by Dr. Ann Kummer. It is called Cleft Palate and Craniofacial Anomalies. It is a remarkable resource that explains all resonance problems, how to evaluate and how to treat them. So, and then again, we describe how severe is there evidence of hyponasality. The tasks that you would use here are a lot of sentences and phrases that will have nasals. And then you have the person say these and see if they tend to change to bilabial sounds. Like someone says, mommy, 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 mommy. If they keep repeating it, it will be Bobby, 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 Bobby. And that is hyponasality. So, and your textbook provides valuable resources and lists of how, that you could use to assess hyponasality. Hypernasality, that is, again, easier to kind of identify. And you can get a clear straw, put it inside of the nair, and have the person say a vowel. Any vowel individually said should not have air coming out through the nose. So you say E, and you could see as the E is, they say E, you are going to see the mist, and the fog accumulating in the clear straw. You could also get a dental mirror. They sell them at different places, sell them at Asha conferences, and you can call the company. They give you a big bag that has disposable ones, and you put it under the nair and say to the person, say ah or E. As they do that, ah, E, then you notice the mist accumulating, and that will be signs of hypernasality. Hypernasality, it would be indicative of one of two things: velopharyngeal incompetence or velopharyngeal insufficiency. Incompetence has to do more with the way the person is using the soft palate. Insufficiency, it could mean that something organic is preventing the palate from actually doing its job. It could be a congenitally short velum, maybe, for example, that is when it elevates, it cannot meet the adenoid pad, and as a result, the velopharyngeal port is open and the person speaks with the hypernasal voice. Cul-de-sac resonance, that is basically kind of a combination when someone has large palatine tonsils and the air is kind of trapped inside, especially also if they also have adenoids, and the air is, and so when the person speaks, the voice is muffled and it's not. So that is cul-de-sac resonance. There's a video I think you might find at the end that might show this. And again, you always explain if there is, then you go and say how severe. And in your report, you should make resonance as an individual category. You are going to look at voice onset and voice offset. For example, when you look at phonation, that's the auditory perceptual value. Look at phonation. The voice onset and voice onset time is characteristic of the stop phonemes. there are 7 stop phonemes. P, B, T, D, K, G, and the A. So these, when you say any one of them, you are going to close the airway completely and explode the sound. So I either call them stop sounds or plosive sounds. So you are going to look and see if the person's voice, the vocal folds, do they begin to phonate, to vibrate before or after, for example, or at the same time as these stop sounds. And the mechanism that you are going to use instruments that are going to enable you to determine the values here. You will see, give the patient a number of, for example, sounds and phrases, and ask them to just continue saying that, to see how long, for example, they can continue saying one phoneme, E, for example, to determine the maximum phonation rate, for example. So ask the person to say pa 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 how many times, or pa ta 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 ta, or ka 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 ka. And the best way to count these is to get a pen, and every time the person says ta ta ta, you make dots, and you make them scattered so that you can count them at the end. Every time they say pa, you make a dot, 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 and then you count them at the end, and then go to your text and count calculate the values of each one, and then compare to the norms, and that should give you your data. So the maximum phonation time, you are going to time the person, say I'm going to ask you to take a deep breath and say E at a certain loudness level, just normally, and a normal pitch, and then have them continue until they cannot say it. That is on one breath, until they run out of breath. And you do this a couple of times, and then you take the stronger, like the one that is the longest you report. And then using the SZ ratio to look for signs of glottal insufficiency. For example, when you say S, your vocal folds are not working at all. They are not vibrating at all. When you say Z, you have now, your vocal folds are making a buzz, vibrating, and also your tongue constricting against the alveolar ridge, that is giving the noise. That noise is aperiodic, and it is combined with the pure tone of the vocal folds. So now, ideally, when you say to the person, take a deep breath, and then start immediately saying, so you time them, and then take another deep breath and do S again. So you have, one, maybe 2 times. And then now take a deep breath and say Z, and continue as long as you can on one breath. And then do it one more time. And then you compare the rate for this, the highest rate for this, and the highest rate for the Z. And then if both of them are equal, they should be equal. If they are both equal, you go back to the text and you have the norms and the values. If they are less than 10 seconds, both of them, then there's some problem there, that the person doesn't have enough air to put enough pressure to make the sound. So if both of them are decreased, that is a breathing problem, okay? Now, when the Z rate is lower, the Z is less time than the S, that means that the vocal folds are not working appropriately, that the closure, the glottis is not closing adequately, and that is a sign of vocal fold problems, for example. So what you do is you divide the S by the Z. If you get a 1, you get 1. That means that you have, for example, a normal rate. And then if you get the Z lower than this, for example, above 1 point, 1 point something, then every time that the higher you go from 1.0, the higher you go, the more evidence that there is a problem there. And so 1.3, 1.4, and each of them, if you go to your textbook, you see the interpretations. But generally, duration of Z, when it is shorter than this, that is the bigger concern, and it points to some evidence or some signs, I would say, of vocal pathology. In terms of instrumentation, now that you have all your description and you made your judgment about the different, the quality of the voice, about loudness, and about the pitch of the voice. Now we want to confirm, and we are going to do some different measurements, but using instruments. And if you are working in a clinic, in a private practice, or working in schools, and you have done the perceptual assessment and you want to refer, you should refer particularly, to confirm your findings. You refer for an instrumental assessment, and then you send your report and you say, I have done a perceptual assessment and these are the results, and I would like to, I recommend the person for an instrumental evaluation or instrumental voice assessment to determine, and you tell them exactly what you would like, to determine if there is, for example, vocal pathology, if the person indeed has vocal nodules, to determine, the status of the vocal folds and their function, okay, using instrumentation. So this is why we call that part of the assessment instrumental assessment, not because it's important. The whole evaluation is important, but instrumental here means that we use instruments. And you as the SLP, if you end up working in a hospital or a medical center, and you are going to be able to administer these instrumental evaluations. So you could do the whole thing, instrumental as well as the perceptual and the whole piece. So the benefits of the instrumental assessment basically is that you have visual evidence and you have physical evidence that is objective, that is neutral. It doesn't depend on, kind of, in other words, you have concrete evidence that this, for example, person presents with, anatomical problems or signs of pathology and so on. The limitations, for example, is that it's going to require a lot of expertise. You are not just going to jump in and do one because it's invasive, especially if you do the flexible laryngoscopy where you do endoscopy through the nose. You put in the camera and it goes over the velum, and you see that is invasive and it requires skill because you could, harm the patient. So it will take you quite some time to practice. You would have to also know your anatomy very, very well, like everyone else. But in that regard, you really should be going into a special training. So the medical settings can do it because you have medical people on staff, and if there's any problem or anything, they will be there to help. But these procedures cannot be performed in educational settings, for example, in school systems or your clinic, if you do not have access, someone, like with medical licenses to help. The acoustic analysis is something that you do as an SLP, that you get instruments. In the clinic, we have the voice analysis system, where you can evaluate pitch, frequency, and intensity values. We use a microphone and speak, and it's going to give you all the data that you have about your voice. It will give you information about your shimmer and jitter and the harmonics to noise ratio. So let's look at some of these. So one of the processes is electroglottography, and that is basically using these electrodes that they put on, and they are going to record values, and then you compare them to data and to determine if there are abnormalities in the anatomy itself, or how the anatomy is used. There's also electromyography that looks at the integrity of the muscles, and also that is measured by the instruments, by electrodes. And then laryngoscopy. The two kinds. One is basically flexible laryngoscopy, and one is rigid laryngoscopy. The flexible laryngoscopy is the one that you go through the nose, and that is, it is called different names, but the one that is a little bit common is video endolaryngoscopy. And there's also video laryngostroboscopy. Making go live. So if you simply say voice stroboscopy, that also is a shorter way. So the endoscopy or laryngoscopy, you just again put the spray to numb the nasal passage, and then you thread the camera. You have to be really skillful, and you just keep going, and it will enable you to visualize the nasal cavity and the area above the velum, and you see the velum, and then you go to the vocal folds and you see the entire area. The advantage of this is that you can have the patient read full passages and say all kinds of sounds and speak normally, and then you see what the vocal folds are doing. This rigid stroboscopy, you just have that camera, which is like almost like one of these grill lighters, and you put it in and have the person open her mouth or his mouth, and you kind of pull the tongue a little bit out, and then you put that in and then visualize the vocal fold stop. There are only a few sounds that you can say while this is in your mouth, like say ee or he, and you are going to look and see how they are vibrating. Each one has its own advantages, of course, and it depends. Sometimes what you need is determined by what the patient requires. This is the system that we have, from in our clinic from Pentax, and you need to just go in the clinic and experiment with it. It enables you to measure your pitch, your intensity, and you kind of it's a cool instrument. It's expensive, but so also you want to see if the patient is able to regulate airflow sufficiently through the airway while they are phonating. You want to look for the breathing patterns. For example, that again, you collect this through observation throughout the entire evaluation. Is the breathing more or less than normal? Are there any signs of musculoskeletal tension to compensate for the poor breathing? Is there any evidence of sufficient breathing patterns? Is the patient able to regulate breathing with speaking? So as you recall, speaking requires the synchronization of breathing with phonating with articulating. So these three have to work in synchrony, and if they fall out of sync, that's going to cause speech problems. Definitely, if breathing is a factor, you are going to look for evaluations in the patient's file, evaluations from a respiratory therapist. For example, you want to look for lung volumes, lung capacities, air pressure, look for signs of asthma, look for measurements of airflow. For example, air exiting the glottis, for example, how much is exiting per second. You can't do this in your own. So there are voice labs that have these instruments as well. And then you have values, normal values that you can compare to. Their aerodynamic measurements have to do with the way that the air is circulating as the air is exiting the larynx, and as it is exiting the vocal tract, how is it going and how is it exiting. So you measure the rate of airflow, and also you measure laryngeal resistance. There are tasks, and you use an instrument, of course, that you put in like a mask, and you're going to be it will be closing completely like this, and you say pee 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 many times, and then it measures the basically intra-oral pressure. How much pressure do you have when you say pa? And then E, it measures your peak air flow. Is there enough air flowing through the vocal tract? So that is, again, you have your own measurements. The machine gives you, records that, and it compared to the norms. It tells you how far this is within, compared to norms. And then you can see, for example, that if someone has a breathy voice, they have lower resistance. Why? Because the vocal folds, when you close them, they are supposed to trap the air beneath them. Now, that means that they can resist the air, and only a small amount is going to pass through as you speak. When there is a problem that is causing them not to close appropriately, then a lot of air will be escaping. That is lower resistance. And the lower it is, the more indicative it is that the vocal folds are not closing appropriately. So if there is a strangled voice, that means the person is closing so much more than they should, and that means that there's greater resistance causing lack of airflow or like minimal airflow. That is basically perceived as a strangled voice. So again, these are values that you will get using the machinery, and you compare to get the if these are normal or not, and then you can interpret them as signs of either low resistance, as signs of, for example, something like vocal nodules, or some kind of, abnormality when between the vocal folds, preventing them from closing, or as some neurological or some psychological problem causing the greater resistance and the tension that is causing the person, to close the vocal folds so much squeezed that not enough air is going up. So again, you do the laryngoscopy exam, the laryngoscopy or the video endo laryngoscopy or the stroboscopy. By themselves, they're not enough to evaluate the voice. You have to do the perceptual aspect, and you have to integrate this with this data. It requires knowledge of the anatomy and knowledge of the aerodynamics, and really very strong analytical skills, because you need what you observe something, and you have to connect it and to interpret, and why this is happening. You have to go back to your textbooks, basically. So there is a form that you use to document the results. There's a form for the endoscopy exam and the form for the stroboscopy exam. Remember, if you work in the hospital, you will be doing both of them, and then you would work with the ear, nose, and throat physician to discuss the medical etiology, the cause, and the exact medical diagnosis, for example, that is causing the voice to be abnormal. Here's a video that this is the Asha link where when you click, you're going to find the rating scale that you use in order to record the results. Part of the auditory acoustic analysis that you do using, for example, the instrument in the clinic is to determine the fundamental frequency. So you ask the person to say ah or e, and then you record, and that is going to show you their pitch, normal pitch, and that they are using, or actually habitual pitch. Ideally, the habitual pitch that they are using on a regular basis should match the optimal pitch. In other words, when they produce it, it's not causing pain and it is not causing a strain. And then you obtain three samples, say ah, 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 and then get an average to see what the frequency, basically the average frequency of that is. But it has to be the same sound. So ah, e, or e, because they have different, frequencies themselves. And then the speaking fundamental frequency, you ask the person to speak through the microphone, and that's going to plot their speaking frequency. And there are norms, of course, for gender and various ages that you can refer to. There are types also of, for example, different tasks and different partners, for example, speaking partners. So the average speaking frequency, for adult males is 112 hertz. The adult female average speaking fundamental frequency is 212 hertz. The child, we are speaking about children from birth to 10 years of age or 11, that is about, when you combine them an average, that's about 251 hertz, male, female, and so on. So the frequency variability for connected speech, you want to determine to what extent is the person able to vary pitch, to bring it up, to bring it down as they speak, so that their voice becomes dynamic. Because remember, if you keep the same pitch and the same loudness, you are going to have a mono pitch and mono loudness that is called monotonous voice, or we call it also monotonous means boring. So as a result, whether children or adults, we learned to make our pitch go up and down as we speak, and we vary it by 25 to 30 hertz up and down as we speak. So as in order to make the nervous system of our listener not habituate to our voice, so that they wouldn't just stop processing what we are saying. We do this also for loudness as well. We need to realize also that when the person is speaking using emotional utterances, that the variability changes more. And when we are excited or angry, the pitch changes are going to be greater. But when we say 25 to 30 hertz, that is the average, normal, spontaneous, regular speaking. And then the frequency variability rate for steady sustained phonation. So that is, for example, the norms are 3 to 6 hertz. In other words, he asked me to say E. So, and keep it exactly the same as say, take a deep breath and E. I am keeping the same rate of vibration as I think I am, but you using the machine, the voice analysis equipment, you are going to detect, because my vocal folds are not instruments. They are not like physical, like two pieces of metal or two pieces of guitar string. They are, they keep changing as I vibrate them. So you are going to see that there will be little changes. Maybe they sometimes go up a little bit, 3 hertz, 3 cycles more, or 6 cycles more, something like that. That is normal. And if they, keep going up higher and going lower, that is not normal. So, higher than 6 cycles or than 6 hertz, that means that there's some problem controlling pitch. That means that the muscles that you use in order to extend the vocal folds to, for example, or they are not working appropriately to control pitch. You want also to determine the maximum phonation range. That means you go from the lowest voice to the highest that you can go, and then you record. So typically, the maximum phonation range decreases with age. Or if someone has a vocal fold pathology, they cannot raise their voice, as well as normal. You should start from the lowest pitch. You go, raise your voice. Oh, and you keep raising your voice with a low pitch, and then you can gradually rise. And because that requires a lot of tension, so you go from the easier to the hard, to the more difficult task. So ideally, the greater the distance between the lowest to the highest, and also you look at the highest loudness level, and you notice that these things are, this testing is conducted in like a sound booth, so that, the person can yell and scream and all of this. So the average habitual loudness is 67 to 80 hertz. That is, the range, range. And when you say 65 plus 80 and then you divide by 2, you get about 70, 72 decibels. And that is SPL, sound pressure level. There's a sound level meter that you use to you hold, and it registers the amount of noise and the loudness out from outside. So what you do is you basically have the person engage in a spontaneous speech or reading out loud, and then at a normal, tell them the voice that you usually use, and then you use the sound level meter and hold it, and it's going to enable you to get a reading and then record it. You sustain, another one sustain 3 times, continue sustaining it, and then take the average of the 3, and in terms of loudness, see if what the loudness level is normally. Maybe if it is too loud, check and see maybe the person has a hearing loss. Maybe it is not loud enough. Look for stress, anxiety, or look for muscular weakness. If the laryngeal airflow is decreased, the maximum phonation range will be higher. So if the maximum phonation range can be used, for example, it can be used as a baseline to determine the effectiveness of the treatment, voice treatment. So it is a valuable kind of measurement that you should get. But just keep in mind that it can be affected by hearing status and by psychological factors. You also need to look for evaluate the average intensity variability. So that means, as we speak, we make our voice louder, and we make it softer as we speak to produce an effect, so that, again, you do not keep using the monotonous voice, and that will make your listeners ignore you. And the normal variability is 10 decibels or, for example, higher or lower than 70. So you might go to 80, you might go to maybe a little bit 60, but you keep changing it as you speak up and down. So there is an instrument called dynamic range or voice range profile. And you basically evaluate from the softest sound that is not a whisper to the loudest sound that the person can produce without physical strain or without pain. And then you look at the range, and that is, for example, the loudest sound that the person makes under these conditions without producing pain. That coincides with the mid-range frequencies, for example. So that when you combine loudness with frequency, that will help you determine what is the best loudness value and what is the pitch that will be best at a certain level of loudness for that patient. Then you ask the person to sustain E, say E, and then get the range, for example, from the softest to the loudest. And then you start with the softest because, again, it's less stressful. And then there are some people who get fatigued very quickly if you start with a very loud sound, and they become exhausted. The task will not be as kind of effective. So you also evaluate the perturbation rate, shimmer and jitter, as I explained, and you use instruments to do so. And the shimmer, as I explained, jitter, refers to frequency. And these are the involuntary cycle-to-cycle variations in between cycles, from cycle to cycle. And every one of us has these variations, but when they exceed a certain value, then they become signs of a problem, usually neurological. And the same for loudness. Loudness, sometimes we call it shimmer, or we call it amplitude variability range. So you can do sustained vowels. For example, say E at what the person thinks, a sound with the same pitch with no change, or with the same loudness with no change, and you kind of measure and see. And so for jitter, less than 1.0, it should be less than 1% change in the kind of variations. For shimmer, it should be less than 0.5 variations. So again, variations mean, like, say the vocal folds are, changing and not steady. The more that you get more than 1% for frequency, the more abnormal it will be. If it is above 0.5, then it becomes an indication that there is a problem with controlling the amount of air going through between the vocal folds, and that could point to breathing problems, possibly muscle. The muscles are not putting exactly the same amount of tension, regularly, and that could become signs of neurological disease, especially in the area of respiration. You also will evaluate harmonics to noise ratio. Remember, the vocal folds produce harmonic tones. They produce pure tones. And then you want to measure that. And in addition, you measure the amount of noise that might be present. Noise means any additional air getting out of the vocal folds when it shouldn't, like in the case of the vocal nodules. That is noise. That is air escaping that makes noise. So when you evaluate, you want to see how much noise is there mixed with the pure tone of the vocal folds. So the normal voice is characterized by high harmonics to noise ratio. It has more pure tones and more harmonics. than noise. So if someone has a dysphonia or has an abnormal voice, or voice disorder, then they will have the opposite situation. They'll have more noise in their voice than pure tones. So we need to consider again these ratios carefully within the context of the entire evaluation and with our perceptual judgment, because by themselves, there are some technical things that might, they might not be as accurate predictors in some cases, but you consider them with the perceptual assessment. And I discussed the SD ratio, 1.0 in normal voices, for example, and functional psychogenic dysphonias. So 1.0 means that the same. S and Z are equal. The greater, for example, if you say 1.2, 1.3, and so on, that will suggest the possibility of nodules or polyps or some kind of abnormality, especially if it goes 1.4 or higher. And the same if there's functional problems of the voice that are making the vocal folds not function normally. And you see, for example, that the value, when you divide the duration of the S, of the longest S by the duration of the longest Z, and you get like 1.4 or higher, that could also point to, functional. It could be also it depends on how the person is using his voice or her voice, or it could also mean that there are some organic problems right there. So there are instruments that we use for acoustic analysis, and some of them are becoming like heart monitors, but we use them for voice, and they monitor your vocal usage, use throughout the day, and you walk around, and then they give you averages, and just like heart monitors. And there are some called portable voice monitoring systems. Some are apps on your phone, ambulatory phonation monitor, daily monitoring system, and so on. And they are connected with your ear, nose, and throat doctor's office, so they can interpret the data. For resonance, the basic conditions, basically, as I explained, you look for a situation when oral sounds exit the oral cavity normally, like all vowels are oral sounds. All consonants are oral sounds except for the three nasal sounds. Other than that, everything, individual sounds, So all of that should be oral. And of course, when you mix and speaking, when a nasal sound occurs in a word, it will affect the sounds before and after it. So this is why we say in isolation, you evaluate this in that case. And nasal sounds. So if these oral sounds are not produced completely through the oral cavity, if there's any air leaking out through the nose, that means hypernasality. And the nasal ones, if there's not enough air going out through the nasal cavity, because, say, of velopharyngeal insufficiency or velopharyngeal inadequacy, incompetence, that means that there's hyponasality, like in large adenoids, for example. So, and there are also nasal air emission. That means when the person basically speaks and they sniff out like that, smile. So that is nasal air emission. It is different than the hypernasality. The hypernasality will be like this. I want to know what I'm going to go there. And so it might not be accompanied with the air emission. Nasal air emission is basically like you are sniffing out. And then the hyponasal, this is an excellent video of the hyponasal voice. and then the cul-de-sac resonance. I couldn't really mimic it, but will help you. And then you just need to be aware of the velopharyngeal incompetence versus velopharyngeal insufficiency, as I explained earlier. The instrumentation for assessing resonance, as I mentioned, you do the cold straw, the clear straw, or the cold mirror to see if there's mist. That means when someone is saying e or ah, and if there is, that means that there's hypernasality. When you send the person to be tested using endoscopy, you should be able to visualize the velum, and you should see how the velopharyngeal port is closing or not closing well to confirm your conclusions. And then you evaluate speech rate as well. Sometimes when the person is speaking fast, that will affect resonance. So it will make it worse, for example. And if the person is not speaking fast enough and ask them to speak faster, that could enhance. So look at these and try them as probes and see if that will make the voice change to the better voice if the person raises or lowers the speaking rate. There are also other instrumentations like the nasometer and nasopharyngoscope. These are instruments that you could use if you work in a hospital. So now, in the case of the laryngeal patient who has had a surgery and taken out the larynx, and the patient will have a stoma here, you are going to provide counseling in terms of what this means to them, how they will, eat, how they will breathe. And then also you are going to try with them different instruments to see, so that they can speak again. And there are different, there are some valves that they use in order to speak, or there are some instruments like, for example, the electrical larynx that they use, and there are different options that are available. They will also, the valves, like a Passenger valve that, you use to basically protect the stoma and prevent the pollution and all of this from going in as they breathe. And they could also use it to speak, basically by making a little, so here is the trachea and the wall of the trachea. Here is the esophagus. So if you make a wall in between the trachea and the esophagus like this, and make that, bring in a little valve, put it outside and insert it so that it will go to the esophagus, then the person can use that to produce speech. So, and there are other ways, but that is your role when you have a patient with laryngeal, doesn't have a larynx anymore, and you enable them to maintain the valve and also to take care of it and to use it for speaking and to basically work with them to facilitate their voice using other instruments, like I said, an artificial larynx, for example, and also educate their family about what, all of these instruments are and how to use them. When you write your report, the voice report is a little bit, much more concise than the language evaluation, for example, report. So you put the patient's identifying information. You always put the referring source. And of course, the identifying information includes date of birth. Reason for referral. You just say the patient was referred due to complaints about blah, 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 blah. Who referred the person? Background. You emphasize the medical history, the course of the disease, like when was the problem first noted? Was there a sudden onset to it? Because there are things that are caused by a sudden onset. Did it develop gradually? Were there any events associated like that you could recall that might have triggered that? For example, someone might have gone to a concert or a game and were, stayed up all night yelling and screaming and shouting, and then they might have had a vocal fold hemorrhage, or something like that. So you need to identify the conditions, the circumstances that, for example, will help you identify when the problem was first noticed, how long has the problem been there, what they have done about it. Is the problem getting worse as time is going by? To what extent is it affecting, their life and their social life and so on, their work? And then the clinical observation section, you are going to document basically what you have observed about their breathing, the tension, any signs of tension, any like signs of depression or anxiety, and they always say as evidenced by, and you give some kind of something to support. This person did this and that. He seems very anxious as evidenced by. The oral mechanism exam, then again, that is the routine that you evaluate, but you look for kind of the integrity of the velum. You look for signs of cleft, submucous clefts. You use a flashlight and look into the nares, look for deviated septums. So, inside of the oral cavity, are there signs of enlarged tonsils? Is the person able to say, and you see the facial pillars, for example, and the back of the pharynx going up and down. So look at the integrity of the muscles, breathing. So also hearing, you need to make a heading where you speak about hearing. If you have not evaluated it and it wasn't a concern, you can simply say hearing was not evaluated formally during the assessment. However, it was judged informally that hearing was adequate for conversational speech purposes. It was noted that the patient uses his or her voice, the loudness, the intensity of the patient's voice seemed to be, adequate for speech purposes without being elevated, for example, abnormally. So that means that, there's no concern in terms of loudness being affected by hearing. Or if the person is mumbling, as is the case with, let's say, middle ear infections or plugged ear canals plugged with earwax. So you notice all of these and write that under hearing status. If you recommend that the person be evaluated by an audiologist, then you can make a statement here as well and explain why you think they should be evaluated. Breathing, if you have data from a specialist, like say a respiratory specialist who evaluated the person or a pulmonologist, then you summarize the results. And if there are no findings, you say things, the evaluation was conducted by Dr. So-and-so on that date, and the findings, there were no remarkable findings. Everything seemed normal and so on. So, for example, if the patient was referred for asthma, and then they do not have asthma yet, there are signs of like they're gasping for air and stuff, like the cases we discussed. That could be the, anxiety induced, kind of asthma, and that you would be able to treat effectively. And then you document you say perceptual assessment results. You document under this heading, the results of the perceptual, your judgment, the voice, in terms of pitch was like this, and loudness was like that, and quality of the voice was like this and that. And then you explain and make your conclusions and analysis. And then results of you make this either laryngoscopy and auditory acoustic analysis findings, and then you describe the findings here, and then probing, you kind of say, these techniques were tried with the patient and they were found to be effective, or they were not found to be effective. It was noted when we did this that the client's voice improved or didn't improve, and then recommendations. So these basically, regardless of what you call them, these are the areas that you would cover under voice. You also would include something here for resonance, resonance status. So you might go to a hospital that has, of course, every hospital will have its own format for the evaluation report, and you will find a lot of check marks, check, so you can do the evaluation quickly and get it out of the way. But these are the areas, like I said, it doesn't matter what you would call them exactly, but if you have these subheadings and the areas and cover them systematically, your evaluation report will be quite effective. So this is going to bring this lecture to conclusion. And these are resources that you will find quite valuable. Some of them also include, treatment and stuff as well. And there are some videos by different cases. And I hope that you watch, especially the spasmodic and hemorrhagic polyp samples. These are all short, like a few minutes, but it will really give you a great idea about how voice disorders are. So that is the conclusion, and I'm happy now that finally we have covered that part of voice extensively as everything else. And we'll see you on Thursday. Thank you.